But
you've actually, over the years, you've talked about this, how just simply the placing of your hands on a patient
that's right.
is a treatment.
That's right.
An aspect of treatment. Some people, they might have gone to chronic pain patients, might have gone to doctor after doctor who's never touched them.
That's right.
Never touched them once. And then you just palpating them is an experience, is that's something.
Right. And we must remember that, when we are looking at trauma, which presents itself, whether it is traumatic or insidious, the trauma that accompanies injury or difficulty in movement, or emotionally drives the very physical presentations we see, we have to remember that they are encoded again in the neuron. The neuron is the basic memory unit. And therefore, any intervention that is deemed to disrupt the memory egg, the neurons that are now wired together, must be utilized in treatment, in the treatment procedure, so that touch becomes really one important part of this aspect, and light touch especially so, and different ways of touching, whether you're stroking, tapping, caressing, vibrating, shaking. They are all ways of entering this modality or applying this modality to your patient, and we should avail ourselves of that, because sometimes the treatment emphasis is not all somatic, it is very emotional, psychological, and therefore you must have a way of accessing those aspects of physiology that are not directly affected by electric current or or a more aggressive trigger point work. Yeah.
I mean, that even extends, I'm thinking, of a few patients where they're the kind, like the one patient I'm thinking of has a high stress job, mm-hmm. and we get along, mm-hmm. they come in, they're very talkative, they like my little jokes that I crack, they tell me about their stressful day, and their physiology is very tight, stiff, mm-hmm. stressed, sympathetic mm-hmm. kind of response. And over the past, few months of seeing them, I've realized, it's not a good idea for me to ask them, so what's the latest crazy thing that they did at your work, and let them report it to me, because it just amps them up.
Yes.
And it's gotten to the point now where when they come into my room, I turn the light down low, mm-hmm. I talk very slow and light. I'm not cracking jokes. I'm not asking mm-hmm. them to review all the craziness, because mm-hmm. that is definitely an aspect of treatment, yes. for them. I mean, I did eventually crack some jokes and say, like, I can just simply put you in this room, let you lie down and read a book for 15 minutes right. with the lights off. It'll be almost as effective as anything. Yeah. I mean, because they just need to calm down. And then yes. there's other ones. It's the other end of the spectrum where they're just mopey and don't want to do anything, aren't stimulated at all. And yes. I need to get them up and moving and going.
That's right. You need to give them a pep talk and get them up and moving. Talk. So that is true. There are some patients who come to my clinic and promptly fall asleep halfway through the treatment. And as long as it does not interfere with what I'm doing, I let them sleep, because obviously they wouldn't do it if they went in dire need to do exactly that. Nobody goes out, visits somewhere else, especially a professional,
and pays
attention.
Money.
Yes, and then falls asleep. Yeah, you wouldn't do that normally. But I think that it just goes to show you that the therapist must be sensitive to the person he's dealing with, in addition to knowing what the diagnosis is. Yeah. So,
in terms of that visceral course, you know, like you were saying, there's an assessment. There is a treatment that includes a direct manual treatment to a particular organ, and a direct manual treatment to particular trigger points, followed by kind of a rechecking of the general assessment. That sounds accurate.
Yeah.
Was there any active exercise? I mean, was there, okay, we're going to use this developmental position to treat, or
yes, there was. There was active exercise to stimulate the stabilization system using the DNS principles, because this was important for example, the diaphragm. It was also important for the pelvic floor. It was important to help release some trigger points, for example, the quadratus lumborum. And by activating the global pattern, it was then possible to have a more effective treatment. So yes, there were exercises, again, easy, simple, and they could be made more complex if you wanted to, but they also involved, again, how to use the developmental kinesiology, the neurophysiology that exists as efficiently as possible to help the patient along the path of recovery.
It's a reflection of that thing we were talking about, I think the last time, where we're less concerned in one sense about like the mechanical aspects or the direct mechanical effects of the exercise, and more, or at least not more concerned, but equally as concerned about the neurophysiologic global effects that exercise has. So this course is a perfect metaphor for that.
Yes, it is. Yes, it is. We must, I think that is very important. And again, that is why knowing what the exercise is doing, why you've chosen it, and its specific effect, whether it is for a segment or a group of segments, whether it is to relax or strengthen, whether it is to help coordinate or uncouple a poor pattern. These are all things that should be in the back of the mind of the practitioner. And then there is the physiological or neurophysiological aspects that come along with, for example, the chemical changes with better breathing, the sympathetic decrease in tone, as the sympathetics get normalized, you get more neurophysiological responses and so on. So hormonal and a lot of other things. So I think that all these allow you to have a multifaceted approach to movement strategies in terms of exercise and treatment. And it blurs the line between manual therapy and exercise. And the exciting part is always to blend these and really see what is it that you need to do and what it is the patient can do for themselves, especially when you're not there, and that they have also a means they have the data that they themselves can check to make sure that they are actually achieving what you are hoping they would achieve in clinic. This self-treatment aspect is the best thing you can do. And, I call it hidden exercises because they are often baked into the ADLs. They are not taken out and put into a half-hour session. And for many people, I think it makes the thought of exercise less daunting when they know that they could do 8 reps in the shower, or 10 reps in the bathroom or in their bedroom, and by being present and having reference points for the exercise, meaning they have pointers that say, yes, if you feel it here and you see this, this is correct. And if they can do those and experience it through the afferent senses, they can start to affect their movement, their quality of movement, their well-being much quicker than if they relied on me to see them 3 times a week for the same treatment. Yeah.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.